Hey everyone, Ryan here, and welcome back to our series on endodontics. Like all my videos, I'm going to focus only on the highest yield topics, and now that we've covered the basics of endodontic treatment and procedural complications, let's talk a little bit about traumatic injuries and the endodontic treatment that can accompany this trauma. So first, I wanted to come up with an easy acronym to remember the basic protocol following a traumatic accident. So if a patient calls you and tells you their kid fell and knocked a tooth, or if you yourself had such an injury, you'd know what to do. So my acronym is trauma, although trauma is spelled a little bit interestingly with a V instead of a U, but otherwise I think it works really, really well. So our T is for tetanus booster. And this is true for avulsions only. And we'll talk more about this, but an avulsion is where a tooth is knocked completely out of the socket. And so in this situation, you'd want a tetanus booster within the first 48 hours if that tooth had fallen in the dirt and got contaminated, and the plan was to have it replanted in the socket. Our R stands for radiographs. And so for trauma, you'd want at least one periapical radiograph. And we'll talk about situations where you actually want more than this. For example, for jaw trauma or suspected fracture, a panoramic x-ray would be recommended. Our A stands for antibiotics. And again, this is for avulsions only. In that contaminated tooth situation, you want to replant it, want to prevent infection, and take some antibiotics. Our U, or I should say our V, stands for vitality testing. And so this involves the electric pulp testing and cold test we talked about in a previous video. And remember, we talked about how they don't actually test for true vitality. And that's important here because false negative results, where it says the tooth is actually dead when it's actually not dead, are rather common following trauma because the sensory nerves in the tooth may be disrupted for at least 2 to 8 weeks following the traumatic event. But vascular supply may still be intact, which is the true measure of vitality. So it's important to have follow-up visits, which is our M and our A, more appointments, and follow-ups are recommended 3 weeks, 3 months, 6 months, and 12 months after the traumatic injury. So I actually already have a video that looks in depth at the Ellis classification system, so if you want more information on this, go check out that video. But this system is often tested on the national board exam, so I thought to mention it here just briefly, and memorizing it is important, and it's kind of nice because it basically goes in order from least serious to most serious traumatic incident. Just to give you a quick glance of what I talk about, some of these are nice to memorize because Class 1 involves one layer of the tooth, Class 2 involves 2 layers of the tooth, and Class 3 involves all 3 layers. Class 4 kills the tooth, Class 5 moves the tooth, and Class 6 kicks the tooth out of the socket. So those are all the Ellis classes. Again, check out my video on it if you want to see more in-depth information. Alright, so we're going to go through a couple examples of different traumatic injuries and what you do to treat them. So an uncomplicated fracture refers to all fractures of teeth without pulp involvement. So they involve just the enamel layer or the enamel and dentin layer, like in this picture here. If only the enamel is involved, smoothing the edges, rounding those edges off to prevent any further soft tissue damage, lacerations with the sharp edges of a fracture line, that would be our treatment of choice. If enamel and dentin are involved, then we would elect to restore that tooth with, let's say, a composite resin or something to, again, restore the tooth to its function and to occlude those dentinal tubules to prevent sensitivity issues, caries, and things like that. Next we have a complicated fracture, And so the uncomplicated fractures don't involve pulp, whereas complicated fracture by definition does involve the pulp layer. So these little things, DPC, SPEC, pulp, PPTY, all of these things I'll explain in my next video on adjunctive endodontic treatment, so definitely go check that out. But here, it's very important that the timing is considered. So all these treatments involve treating the pulp tissue to some degree because the fracture involves the pulp. And which one you do depends on how long after the fracture has occurred that patient presents to the clinic. So if it's less than 24 hours, we can get away with a direct pulp cap. If it's more than or equal to 24 hours, we'd have to do a SPEC pulpotomy where we remove part of the coronal pulp tissue. It's a partial pulpotomy is another name for it. And if it's been more than or equal to 72 hours, we do a pulpotomy where we remove the entire coronal pulp. All right, so horizontal root fracture is our next one, and this one's a little bit tricky, but I'll try to break it down to make it a little bit easier to understand. So this is where the coronal segment has been displaced and the apical segment is not displaced. It's still lodged in the socket. This coronal segment might be a little bit mobile because it's fractured off of the rest. So in this one, as I alluded to before, this is a scenario where you'd want to take more than just one periapical. In fact, you'd want to take 3 periapicals and 1 occlusal radiograph at a minimum. And this is because a fracture like this occurs along one plane of space. And if the radiograph is captured along a similar plane, you won't be able to see the fracture line in the image because an X-ray is a 2D image of a 3D object. And so this is why it's super important to take several radiographs at different angulations. All 3 of these PAs should be taken at different vertical angulations, as the occlusal is a different angulation, 90 degrees to the long axis of the tooth approximately. And hopefully with all of those radiographs, you'd be able to see where that fracture is. So ideal healing of this fracture is calcific healing, otherwise known as calcific metamorphosis, which involves reattaching these 2 fragments together in close proximity via calcification. So it's basically a callus that holds these fractured pieces together by hardening along the fracture line. And we'll talk more about this when we talk about responses to trauma, like natural responses of trauma by the tooth at the end of this video. So next, I can get caught in the weeds a little bit here, so I'm going to keep it pretty simple and say that if the tooth is vital, if this coronal segment is vital, we'd want to splint that tooth as soon as possible because it's probably quite a bit mobile, and we want to keep it relatively in place so that we can allow some sort of healing response. And so if the fracture is in the coronal third of the root, we'd have to use a rigid splint, unfortunately, which is not our first choice generally because it can lead to the side effect of ankylosis. And if the fracture line occurs more towards the apical third of the root, that's better, and we can use a flexible splint for a less amount of time. And that's because we want to avoid ankylosis if possible. So a flexible splint, and the less amount of time you can use it, you can get away using it, that's better for avoiding these potential side effects. And as you can see here, the coronal fracture is much worse than the apical fracture and involves a much more complicated, involved treatment procedure. So apical fractures are better than coronal fractures, which is also true if you recall from our last video. Perforations, one of those procedural complications, are better if they occur apically as opposed to coronally. So just another example of kind of those trends that you can remember. Apical is better than coronal. Also, an oblique fracture is better than a transverse fracture that goes straight across. So that's another thing you can keep in your memory banks. Now, if the tooth is necrotic, as in, most situations where the tooth is necrotic, we'd want to do a root canal therapy. So that makes sense. Now there's a 25% chance of necrosis of the coronal segment of the tooth, and necrosis of the apical segment is very, very rare. So it's a rare situation where you'd have this segment that was not dislocated, not displaced, become necrotic. So the root canal therapy would be involving sealing off the wide lumen of the pulp in the coronal segment and leaving this segment alone. If the apical segment does happen to be necrotic, we can extract it or surgically treat it. Okay, so next we have concussion, which is where you bumped your tooth, like you bumped your head. And so there's no displacement, no mobility. The PDL may be a little bit sore, like you stub your toe on the door frame. Yes, your PDL will be sore as well. And for a concussion, our treatment, as you may have noticed, all of the treatments I have are listed in red because they're extremely important, because those are the things you'll most likely be tested on the national board exam. You want to let the tooth rest for a concussion. So this involves avoid biting on it for a few days and stick to a soft diet if you can. Next up is subluxation, which involves the tooth being loosened in the socket. So there's no displacement like concussion, but now we have some increased mobility. And also the PDL rips and bleeds as a result. So if a patient presented in your office and said, they bumped their tooth, it's really sore, and you saw some bleeding around the sulcus of that tooth, that should clue you in, this is not a concussion. We're definitely at least at some subluxation. So subluxation should be best treated with a flexible splint for that ideal short period of time, 1 to 2 weeks. There's a 6% chance of necrosis with closed apices, and it's more favorable prognosis with open apices. And so what I mean by this is an open apex means that it's an immature tooth where the root is still developing, and that's a better situation. And a closed apex means it's a mature tooth where the root has completed development about 2 to 3 years after the tooth has fully erupted. Next we have extrusion, where the tooth is partially extruded in a coronal direction out of the socket. Again, open apex, a little bit more favorable. We would reposition that tooth in its socket, use that flexible splint for about 1 to 2 weeks, and monitor it as needed. Again, stick to our follow-up recall of the those couple weeks, the months, and the year, and all of that. Closed apex, a little bit less favorable. Still, we would want to reposition it, place a flexible splint, and root canal therapy if needed if that tooth becomes necrotic, because yikes, there's a 65% chance of necrosis with closed apices. So as you may notice, as I'm going through this presentation, the traumatic injuries are getting more and more serious with a worse and worse prognosis in terms of necrosis of that tooth. Alright, next we have lateral luxation, and this is where we have displacement of the tooth in any direction except axially, hence the lateral part of the name. So usually this means the crown is displaced palatally and the root apex is displaced labially, as in this image here. So if I got my pen out, this crown is dislocated palatally and the root tip is dislocated labially. And here, unfortunately, we have alveolar fracture, which is definitely more serious and would involve a more extensive splinting option if we were trying to repair that fracture. But this is certainly more sinister. Now we'd have the same treatment options as extrusion, as I just alluded to, so that's reposition, flexible splint, and monitor with root canal therapy as needed. So if the tooth becomes symptomatic, if there's irreversible pulpitis or necrosis, we'd have to step in with root canal therapy. And here we have 80% chance of necrosis with closed apices. So definitely not a great prognosis here. Alright, next we have intrusion. And this is apical displacement of the tooth. So this tooth is displaced in this direction. And I'm going to jump ahead. There's a 96% chance of necrosis with closed apices. That's really, really bad. And that's because as the tooth is displaced in an apical direction, it literally severs the vessels that supply that tooth. It pushes on these vessels that supply it at the apical portion, and that's the life supply of the tooth. So intrusion is just cutting that off. And so necrosis is super, super likely in this situation, unfortunately. Now, there's two very different treatment options depending on the nature of the apex. If it's an immature tooth, we allow it to re-erupt. And this is really, really, really important. I've definitely seen quite a few questions on the board exam about this exact topic. So if it's intrusion, an open apex, you actually do nothing other than monitor it and allow it to re-erupt on its own, because the root is still developing and there's a chance that it pushes that tooth and continues eruption with a couple of hiccups, but continues that eruption otherwise as normal. Closed apex, we go to our classic repo, flexible splint, and root canal. Alright, and lastly, we have avulsion, which I alluded to before, otherwise called exarticulation. And this is complete separation of the tooth from its alveolus or from its socket. So the tooth has just completely been knocked out. Like my example, I may have said in another video where I got hit in the face with a baseball as a kid, a couple of teeth got knocked out. That's an example of avulsion. Very, very traumatic. Trust me. So important concept here is extra alveolar dry time, or EADT for short. And this refers to the amount of time a tooth has been out of the mouth while dry. Hence extra alveolar, outside the socket, dry time. And this is a really, really critical concept, because the more time you wait while the tooth is out of the socket, the worse and worse and worse the prognosis of saving that tooth becomes. Kind of true for all the things we've talked about, the amount of time between the incident of trauma and seeing a dentist. Same thing here. So avulsion, our treatment is basically, this is kind of generalized, we want to re-implant as soon as possible, meaning put the tooth back in the socket, with some exceptions, and flexible splint for 1 to 2 weeks. This is a little bit of a overgeneralization, but just maybe for test purposes, remember re-implant and flexible splint. Now, for a little bit more detail, like I said, it very much depends on this closed apex versus open apex concept we've been talking about most of this video, and the amount of time that tooth has been out of the mouth while dry. So you can read through these on your own. It's basically, again, worse as you get over 60 minutes. Prognosis of the tooth goes way down, and the sooner you can get into the dentist, the better result, and less than 30 minutes is ideal. And it may be worth noting, these protocols are for permanent teeth, as it's not usually recommended or necessary to be re-implanting primary teeth that are knocked out. But in the case of primary tooth trauma, our trauma acronym that we started with is still by and large critical that the young patient follows and should absolutely see a dentist right away. Staying on the topic of avulsion just for a few more minutes here, we have different storage media. So when that tooth is knocked out, instead of keeping it dry, we have some options on how to save it as best we can for the time being while we're driving frantically to the dentist office. So our best optimal solution is called Hank's Balanced Salt Solution. Or here's Save a Tooth is, I guess, one of the names out there of the product. And we also have milk is not a bad option, saline, saliva, if the patient is not a child and can maybe hold the tooth in their mouth for the time being without swallowing it, that's another option. And actually, water is the least desirable solution out there. It might not be what you think, but yeah, water is actually very not great for trying to save the tooth because it's hypotonic. It doesn't have the correct balance of ions to be helping the tooth survive for that little amount of time. So finally, we'll talk about different long-term responses to trauma. So these are like natural responses, what can happen to the tooth after a while after this traumatic incident has happened. So our first big one is external resorption, and this initiates in the periodontium, and this is due to damage to the cementoblasts, the cementoblastic layer of the PDL, which comes up right to the tooth. And so we have a couple different subcategories of external resorption. The first one is replacement resorption, which I talked about before is a bad side effect of having those splints that are too rigid or left on too long. And it's otherwise known as ankylosis, where your body replaces PDL with bone, hence replacement resorption. There's also cervical resorption, which is subepithelial sulcular infection resulting from trauma, or evidence is still a little bit shaky on this, but potentially non-vital bleaching. So subepithelial, meaning under the epithelium in the sulcus, basically means it's initiating at the CEJ of the tooth. And it's this often ragged moth-eaten appearance in the radiograph. This one's actually a little bit more clear. Maybe up here it's a little bit moth-eaten. And you could spot a pink spot in the tooth clinically. Next we have inflammatory root resorption, and this is where bacteria and byproducts from the necrotic pulp travel through dentinal tubules to affect the periodontium. So they go from in the pulp to outside and impact that PDL to get another kind of external resorption effect on the tooth. So margins of external resorption are ragged, poorly defined, and if you take several different angles of radiographs of periapicals, the lesion appears to move with those different angles. Now that'll be important when we compare it to the next one, internal resorption. So as opposed to external, this one initiates within the tooth, in the root canal system, due to damage to the odontoblasts. So inflammation is due again to necrotic pulp from caries or trauma, but this time causes resorption from within, rather than from the outside, from the PDL. So internal resorption has a bit better prognosis, is a little bit easier, or much easier to treat than external resorption. And you actually treat this with root canal therapy. And you can use a liquefied or flowable obturating material to flow into this area of resorption and seal the canal effectively, as long as it's not too involved. The margins, as opposed to external resorption, are sharp and well defined, as you can see here, and it does not move with angled radiographs because it's located in the center of the tooth. So it's going to stay in the center of the tooth no matter what angle you take the radiograph at. And lastly, we have our ideal natural response to trauma, which is calcific metamorphosis. And this is where trauma induces odontoblasts to rapidly form extensive amounts of reparative dentin. Remember, that's one of our tertiary dentins within the pulp space. And this is more likely with open apices, intrusions, and severe crown fractures. As a result of this calcific metamorphosis, you get kind of like a yellow-orange color of the tooth. And again, it's a sort of callus that forms that causes this coloration, and it's actually the ideal response to trauma. It also results in this phenomenon known as canal obliteration, where the pulp canal shrinks to the point where you wouldn't even be able to see it on a radiograph because of this deposition of reparative dentin, where the tooth basically prepares itself. It lays down more tooth structure to protect itself, and that's again the natural ideal response to a traumatic injury like luxation or intrusion. All right, so I know that was a lot of information. Feel free to rewind and rewatch some of those things because there's a lot there, and this is all important stuff. Because as I said before, some of the sections of the test, particularly that ask about case scenarios, they could reference some sort of trauma, and they would ask you, what would be your ideal treatment modality, what you would do, what's the prognosis, what's the rate of necrosis, maybe not exact percentages, but maybe rating what the worst traumatic injury would be, what's the best prognosis, things like that. So all that stuff is rather important, and hopefully I was able to deliver it in a way that helps you remember it and can help you study for the national board exam. So again, thanks so much for watching, guys. I really appreciate all the support. I'll have the next video in this series up pretty shortly, and then after that I'll make some practice questions like I did for the oral pathology section, so you can get a taste of what some of those board questions will look like. Thanks again for watching, and I'll see you all in the next video.